Welcome back everybody, David here again with Med School Bootcamp. So now we're going to move on to our next chapter, which is dealing with the nephritic syndromes. This is really important to complement to the previous chapter where we talked about nephrotic syndromes because they're going to expect you to be able to compare and contrast some common nephrotic syndromes versus nephritic syndromes. And you do this by remembering our overview video in which we talked about some of the key differences with the nephrotic presentation, how it's involving more proteinuria, and then we contrasted this with some nephritic syndromes which also present with proteinuria, although typically less than a nephrotic syndrome, but it also has some other findings, including red blood cells that might be present in the urine. So now we're going to take even a deeper dive into some of those nephritic syndromes and talk about some of the most commonly asked about ones that you'll be expected to know on test day. To finish this chapter, we'll have a nice summary video where we will compare and contrast some of the common nephrotic and nephritic syndromes and give you one or two things to really distinguish these pathologies. That way, if you were asked about the pathologies in a question stem, you have an idea of some of the key differentiating factors that will lead you to the right answer. So if you all are ready, then off we go. So in this first video, we're going to talk about something called post-streptococcal glomerulonephritis. So first we're going to start with the pathophysiology, which as you can probably guess, involves a streptococcal infection. It most commonly involves the group A beta-hemolytic streptococci infection, which involves a specific surface antigen that classifies it as a group A. This is not to be confused with our group B streptococcal infections. What's important to know about this strain is that it's nephritogenic because it contains something called the M protein virulence factor. And what this is saying is that this particular strain is known to lead to things like nephritis. It's also important to note that this type of infection with group A strep typically follows a skin infection such as impetigo or a case of pharyngitis. So following these conditions, we can get this immune complex deposition that leads to complement activation and ultimately glomerular destruction. So how does this actually occur? Well, it's important to note that post-streptococcal glomerulonephritis is actually a type 3 hypersensitivity reaction. And what that means is that part of the group A strep is actually broken down into an antigen in the body. This can then bind to an antibody, forming an antibody-antigen complex, also called an immune complex. These immune complexes can then make their way to the glomerulus and become trapped in the glomerular basement membrane. These immune complexes being trapped in the glomerular basement membrane and then the activation of the complement system is what leads to glomerular destruction. Because essentially we have a foreign substance in our basement membrane, this is going to activate our immune system and our inflammatory markers to come to the area and help out. Well, guess what happens when that occurs? You get damage to an area that ultimately affects our filtration barrier. This is the reason why we start to see these symptoms in these patients of a nephritic syndrome where they have proteins or red blood cells that are filtering through because we've damaged the barrier. That would typically keep these substances out of our urine. So how do we diagnose this condition? Well, there are a couple well-known antibodies involved, including anti-streptolysin O antibodies or anti-DNase B antibodies that we can test for in the serum. Additionally, we would expect to see hypocomplementemia or decreased C3 in the patient's serum. Why? Because we're experiencing complement activation. That is, the C3 is being used up in an area in the body, and thus there's less of it floating around in the serum. Now, it's important to note that hypocomplementemia itself is not enough to make this diagnosis because this can be seen in other conditions such as membranoproliferative glomerulonephritis, which we'll talk about in an upcoming video. However, these antibodies are unique to PSGN, and so they are a better indicator, or they are a better test if you're working up a patient for this condition. It's also important to know some of the key pathologic findings, and that includes hypercellularity of the glomeruli on light microscopy, which you can see here. Now, if you compare this to a normal glomeruli, you would see a lot more space or kind of open whiteness in the image, as well as fewer cells. But here you can just kind of see a dense packing of cells and stuff is how I think about it. There's a lot of stuff crammed in this glomerulus, and this density of stuff, which is a collection of inflammatory markers and immune complexes, is an indicator that we are dealing with post-streptococcal glomerulonephritis. Other imaging that we might look at includes subepithelial immune complex humps on electron microscopy. So this is a really similar pathophysiology to what we talked about in the membranous nephropathy video, but essentially we have these humps right here, and these are due to the deposition of our immune complexes into the subepithelial space. And what happens when we pack more stuff into a limited space? Well, this can cause an expansion of the glomerular basement membrane. So we now get a presentation that looks like this, where we have these humps that have developed in the glomerular basement membrane, and that's what you're seeing right here. these dark spaces, is equivalent to this process where complexes have deposited and the glomerular basement membrane has expanded. And finally, you can see a granular appearance on immunofluorescence in what's called a starry sky or lumpy bumpy appearance. These immune complexes contain IgM, IgG, and C3 because when we get our type 3 hypersensitivity reaction, these are the molecules that are involved with that pathologic process. And so you can see that down here on immunofluorescence. This is supposed to look like a starry sky appearance, but the key point here is that this is a granular appearance, as in they're spread out all over the place. This is not a uniform presentation of the immune complexes. They're kind of random in terms of their presentation throughout the glomeruli, but they're spread out in various different areas. And that's why you get this starry sky appearance. Next, let's move on to some of the management options for this condition. So one of the important things to know here is that this is often a self-limiting condition, and so supportive care is really the mainstay treatment option. The reason it's self-limiting is that it typically occurs in children, and children are usually able to bounce back from this type of pathology. However, that is not the case for all of them. Some children can ultimately develop renal failure from this, and if this presentation is given to you in an adult patient, it's a little bit more concerning because approximately 1/4 of those patients can develop what's called rapidly progressive glomerulonephritis, which we'll talk more about in an upcoming video. And so overall, adults do not typically have as favorable of a prognosis as children would have. And that's important to keep in mind as well. So we say that it's a potential renal insufficiency in adults, less commonly in children, although still possible. And to finish this video, I want to talk about some really important associations that are going to allow you to really understand this principle and also be able to apply that information to test questions. So first, it's important to know the timeline of this condition. We say that this most commonly occurs in children, approximately 2 to 4 weeks after a strep infection, which can include an infection of the skin or the pharynx. Typically, a pharyngitis presentation comes on a little bit sooner, so maybe closer to that 2-week mark, and the skin infection might show up a little bit later, maybe closer to that 4 weeks, potentially 5 weeks. Again, these are not hard cutoffs, right? It's not like a patient has to present exactly 14 days after, right? There's some wiggle room here, but I'm trying to give you approximate cutoffs just so you have a general idea of what time frame we're talking about. The reason this is so important with this condition, and one of the classic ways that they will try to trick you, is to compare it with another pathology called IgA nephropathy. These can present very similarly, as these are both considered nephritic syndromes, but IgA nephropathy occurs within days of an upper respiratory infection. So again, compare 2 to 4 weeks with something that might be like 2 to 4 days. The reason this is so high yield is because a classic question stem or a classic vignette can present very similarly. They can say something like a 5-year-old child presents to a pediatrician with their parent. They're having various symptoms that we associate with a kidney pathology, such as swelling or changes in their urinary color, and that they've recently felt under the weather or had an infection or sore throat or something that we associate with maybe the common cold. And the key distinguishing step, the key way that they're going to get you with this question is to give you the time frame. Is this patient presenting 3 days after they had symptoms, or are they presenting 3 weeks after they had symptoms? And a really challenging question, that might be the only differentiating factor between these two pathologies. And of course, they're going to give you both of the option choices to choose from. So that's why I'm emphasizing this, and I put a high yield button by it, is because knowing the time frame for these pathologies to present can make all the difference in getting this question right. It's additionally important to know some of the common buzzwords that they will use, and the classic one for this is going to be tea or cola colored urine. Why is this? Well, remember, this is a nephritic syndrome. So in the last chapter, we talked about nephrotic syndromes, which did not involve any hematuria or red blood cells being involved in the urine. But here in nephritic syndrome, the damage that's done actually allows some red blood cells to get through. This can change the color of the urine, potentially giving it a tea or cola colored appearance. And finally, the last thing we're going to talk about is hypertension in a child is typically talking about some type of renal involvement. It's rare for a 5-year-old to have high blood pressure. There are some pathologies that can cause it, but if you see hypertension being presented in a child, I want you to think about a renal involvement right off the bat. And then, of course, this condition shares a lot of similarities to our nephrotic syndromes in that we lose protein in the urine. So we might have hypoalbuminemia, and we know that lower amounts of protein in the vascular system decreases our oncotic pressure, which can ultimately cause this presentation of edema or swelling in the patient. So just to summarize some of the high yield points I want you to take from this video is that the pathophysiology here involves a group A infection that leads to immune complex deposition. These immune complexes then damage the basement membrane via activation of the complement system, which can allow for leakage of substances into the urine, which we would not typically expect or want to be there. This classically presents in younger patients, such as children, with tea or cola-colored urine and hypertension. It's super important to be mindful of the time frame here. Is it approximately 2 to 4 weeks since their symptoms, or is it a couple of days since their symptoms. This is how they can trick you with IgA nephropathy. If we were to work up these patients, we would want to talk about their history and get a physical exam, but we could also do some other things, such as getting some labs looking for certain antibodies, including the anti-streptolysin O antibody or the anti-DNase B antibodies. And although it's not often necessary, if we were to get a renal biopsy, we would see some hypercellular glomeruli on electron microscopy or some subepithelial humps on light microscopy. We can additionally see a granular appearance on immunofluorescence. And why does this make sense? Because remember, this is immune complex mediated. If something is immune complex mediated, that means we can see it on immunofluorescence. And finally, the management for this is typically just supportive care. However, it is important to be mindful that some children can involve serious renal problems, and if this occurs in an adult, it's more likely that they might have serious renal complications.